Good evening, everyone. Welcome to the living room. Thank you for coming, everyone in the room and everyone online who might be joining us. Welcome, welcome, welcome. There are some new people in the room tonight. Hopefully there's lots of new people online as well. We're very happy to have you. My name is Danielle Hicks, and my role here at the Foundation is to oversee all of our patient programs and services. So anything that has a patient touch is my area of responsibility, of course, with an amazing team of people working with me to ensure that this program, as well as many others, go off without a hitch and are very successful. So we're very happy to have you here tonight. We're very happy to have Dr. Jack West here from Swedish Medical Center up in Seattle.
Hi.
Jack is a longtime friend of the Foundation, an amazing medical oncologist, and he's going to talk about some really new and exciting things that are literally hot off the presses and what it might mean for you. But what I've decided to do is, rather than me try to read from a piece of paper someone's bio, let them introduce themselves, say who they are and why they chose lung cancer. So with that, and before we get into the education part, I'm going to turn it over to Dr. West to introduce himself.
Thank you. Hi, I'm Jack West, real name Howard, just lazy witness relocation. And no, but I grew up in Cleveland, Ohio, and between that and working in lung cancer, it keeps things real. And so I really like to have it be casual. I trained on the East Coast and then moved, well, actually, because I'd grown up in Cleveland and then was up in Boston for my training, I was driving to work in January and sliding all over the road thinking, it would be really nice to not risk my life going to work every day. And I decided I'd really like to be on the West Coast and came out to Seattle and trained at Fred Hutch for my fellowship specialty training in medical oncology, and have been up there now for 20 years. And though there's a gravitational pull to California, I'm still pretty happy with it. Rains in Seattle, but I'm never going to complain about the weather having come from where I have. So anyway, I practice now at Swedish Cancer Institute, which is a large private center, a very big tertiary and quaternary care referral center, a lot of good lung cancer treatment, and it's great that I'm part of a solid team that works very closely together there. I had I focused in lung cancer in my fellowship training because I really wanted to work on a common cancer where there was such a need. And I'll just say, as a historical context, that it's astonishing how far things have gone. I know in the thick of it, there's daily challenges, but it's so different from when I started in it. People would ask, why did you choose lung cancer? Like, what's wrong with you? It was a hard field, and when I was in my fellowship, the question that was being asked in like the major journals and conferences was, is it actually doing anything to treat metastatic lung cancer? Are we moving the needle by giving chemo? And it was just becoming established that giving chemotherapy did help people live longer, but it was not so dramatic that you wouldn't ask the question. And amazingly, gratifyingly, over the last 2 decades, it has changed incredibly so that now lung cancer is a field that is among the most dynamic in all of cancer care. And I have friends from medical school who are not oncologists who say they resent that the New England Journal's just full of cancer developments all the time. And my colleagues in other cancers are kind of jealous of everything that's happening in lung cancer. It's dizzying. It's like the found money dream, how quickly things are happening in the field. And it's hard to keep up. And I think that's one of the themes that I would say about it's helpful to connect with somebody who eats, sleeps, lives, and breathes lung cancer, just because there have been a lot of developments in many other cancers. You just can't keep up with everything. And but with that, there's a lot of new developments all the time. Literally, the field has been changing even based on presentations done yesterday. It's no exaggeration. And there was a big press release of some work last week that I was thinking about doing a video on. I do some videos at home and put them out for people. And I thought, well, there's no point in doing that because even if I turn it around in 48 or 72 hours, I knew there was going to be big news yesterday. It would only have a shelf life of 2 or 3 days before it was obviated. So it's a good problem to have. Those are the highlights.
That's great. So a couple things I want to point on that you said, Jack, before we move in is one of the things is how fast things are happening because
Right.
you've been in this space clearly
20
way
years,
way longer than I have. I've been in it since 2003 when you were diagnosed, and I've surrounded myself with everything. But you said something very important. It is changing so quickly, which is why we try to drive home in this meeting and throughout everything we do, why it's so important to see a physician. Most patients are seen in the community setting, right? And those of you who have been here and been coming to this meeting for years, some of you know that this is me beating the dead horse, but community physicians don't have the luxury of being able to specialize in any one, two,
Some.
three,
I mean,
four, some.
Actually, just to clarify, I work in a community setting. It is fair to say most community-based docs are not super specialized.
Correct.
But, you know, in truth, I would just say that it's very helpful to see somebody who is really focused on thoracic oncology.
Correct.
At least sometimes. And that's not to say you don't actually have to get the treatment by that person all the time. The Keytruda in whatever community is the same Keytruda at the specialty center. The antibiotics are the same. So you don't have to do everything. You don't have to get every infusion at a 90-minute drive away.
So with that,
Okay.
let's get started on the topic.
So I'm going to stand for this so I can refer a bit to the slides, but they are not that detailed, and it's not going to be too much. And so I'm going to be talking as a very general introduction to the concept of immunotherapy and kind of where it's been historically, which is not ancient history. It's really just in the last few years where it is today, and I should qualify that by literally today, not tomorrow or next week, because that could be different, and the future, where we're going. And this is, I think you're hearing the theme, a very rapidly evolving space. We are still babes in the woods learning about this. And so, but I think that one of the key themes is this has been a big field, a big advance. It's not going to be the answer for everybody, but it has been a fundamental change and a big, important tool for many people, if not everybody. Okay, next slide. So I'm not going to go into much detail about how the immunotherapy works. The immune system is very complex, but what is worth knowing is that like a lot of complex systems in the body, there is a balance where you don't want too much and you don't want too little. Just like clotting and bleeding. I mean, you don't want to get a blood clot because your blood tends to clot too easily when you sit down in the car for 2 hours, but you don't want to be bleeding all the time for no good reason. And there are many factors that help control that balance. And the immune system is the same. Your immune system is designed to identify foreign threats and attack them when you have an infection, or cancer has some role in that because people who have significant immune suppression after, say, an organ transplant or a bone marrow transplant have higher risks of developing certain cancers. So the immune system does have a surveillance role trying to identify various foreign things that include cancer, but we don't want it to be so overbearing that it's attacking bystander cells in your body. And that's what autoimmune diseases are. And there are many, everything from rheumatoid arthritis to ulcerative colitis, vitiligo, various thyroid diseases, lots of diseases in the whole world of illness are caused by the immune system getting confused and attacking your own body cells as an innocent bystander. And so the treatments that we have are largely focused, the ones we're going to talk about today are mostly at the bottom right of this, and this is what happens at the tumor level. There's a tumor cell, which is the little blue, and then there's T cells, which are the muscle. They're the police force out there, and they interact by recognizing proteins on the cancer cell, which is the little blue dot called a peptide. That's just a recognized little bit. And then there's this interaction between receptors called PDL1 or PDL2 and then PD1. And they connect with each other. PD1 is on the immune cell side and PDL1 is on the tumor side. And they connect and shake hands. And when that happens, it actually is a reassuring thing for the tumor cell. Says, I belong here, nothing to see here, I'm no threat to you. It's kind of like the magnetic badge I use to get into my clinic. But you can make counterfeits, and that's what the tumor does. The tumor has these ID badges that it shouldn't have, but that's what this PDL1 protein is kind of like. It's a protein on the cancer cells that tells it's an invisibility cloak, essentially, that tells the immune system, I belong here, go on to your business. So we've talked about this PDL1. You saw a kind of cartoon version of it, but it's just a protein that is on cancer cells sometimes. Not every cancer cell, not every tumor has cancer cells that have this protein. Some have a lot on most or all of their cancer cells, and some tumors have some on some of their cancer cells, and some have none anywhere, and that's shown here. This is staining patterns, it's called a TPS, or tumor proportion score, of essentially 0 or less than 1%. So it's just what proportion of the cancer cells have this protein on it, which stains brown. This is one magnification, and this is a more detailed magnification, so you can more see the outline of the individual cells. But lots, a little, or none. And so different studies have included anything from all of the patients across the spectrum to just focusing on the patients with the highest level of the protein, to sometimes just some or a lot, but not including those with none. It's been everything, and different companies have had different priorities for this. It's about a third, a third, a third in proportion. It's somewhere in that range, about 30%, and so it's very close to a third, a third, a third as a basic breakdown. And this PDL1 is, as I say, just like the security badge, false sense of reassurance. And what we've generally seen as a rule is that the patients who have tumors with the highest level of expression have tended to be the ones with the highest chance of responding well to immune therapies for the longest period of time. Let's move on. So the challenge is, this is one of the big benefits of immune therapy, is that you can get dramatic and long-lasting responses. And in large part, many patients can feel great on this and have no side effects. The most common side effects we see are a little fatigue, maybe a rash, or nothing at all. But there's no treatment for cancer that is risk-free. And immune therapy is no different. The immune side effects are just very different from chemo, and those are very different from targeted therapies like Tarceva and the ALK inhibitors, et cetera. So they're different, but the immune therapies, of which there are several drugs that we're going to be hearing about, you'll see on TV, et cetera, all share remarkably similar side effect profiles. And as I said, in most patients, they're mild, but a minority of patients can have more serious side effects, and they're the double-edged sword of stimulating the immune system. It's the immune system attacking bystander parts of your body. And the problem is just about anything can happen. Anything with an itis after it, dermatitis, colitis, nephritis, these are all just the words for inflammation of the skin, inflammation of the lungs, inflammation of the liver, inflammation of the kidneys. You can have just about anything get inflamed from your immune system getting confused and going after a bystander cells in an organ. But the liver, the kidneys, the colon, the lungs, the thyroid, various other glands like the adrenals, these are all things that can happen. And there's a very long list of 1% or less possibilities. Most of these are about 1 or 2% chance of being more significant. But when you put them all together, it's somewhere in the range of 10 to 20% of patients need to take breaks from or stop immune therapies because their immune system is causing problems. And I've had patients who have to stop because they get inflammation in their lungs or their kidneys are bothered by this. And very often, if you stop the treatment, that just gradually gets better. So this is where things started. Publication in 2015, a couple of them, from work done in 2013 and 14. 2 different trials, and they are patients who have gotten prior chemotherapy and were then moving on to a second treatment. And the standard older treatment regimen that is still FDA approved and has a survival benefit is a drug called Taxotere or docetaxel. And that was what we call the control arm. So half the people got that, and half the people got Opdivo, also known as nivolumab. And the trials were essentially the same trial, but, the numbers, there's a smaller number of people. This should be, one is squamous and one is non-squamous. I'm sorry I copied that incorrectly. But they're essentially the same exact design. Just one group of people had squamous cancer, which is about 20 or 25% of what's out there as non-small cell. And the other group of patients had non-squamous, which is the other 75% or so. They were otherwise the same study, and they both had the same results, which is that you had a clear survival benefit and a higher response rate and a longer time until progression in general in the patients who got Opdivo, and fewer side effects. Taxotere can be a challenging one, and as I said, though Opdivo wasn't a freebie in terms of side effects, it was easier, and people lived longer. And it was many months longer on average, with some doing way better. In fact, I have a patient who is on one of these original trials who just is now 5.5 years out with no evidence of her cancer. And she was going to go on hospice if this didn't work out, either if she couldn't get on the trial or if she progressed on it. Yeah. This wasn't a slow process. Her cancer was pretty virulent, and it stopped cold. It got so much better that she came back a week later and said, I think my pain's getting better. And I thought, well, that's the placebo effect, because I don't think it's going to work in a week. But yeah. I'd like to say that that's the way most or all of my patients did, but unfortunately that's not the case. But it's exciting to know what's possible. Let's move on. So what we ended up with was first Opdivo, and then Keytruda, studied a little after that, and then another drug called Tecentriq or atezolizumab. These are all similar drugs. 2 of them, Opdivo and Keytruda, work as blocking PD-1, and Tecentriq blocks the other side of it, PD-L1. But they had the same results, essentially. They all directly compared to Taxotere in the same kind of populations, and they all had a survival benefit and very similar side effect profiles compared to each other. And they all got approved with slightly different requirements. 2 of them are Opdivo and Tecentriq do not have any requirement for any level of PD-L1, and Keytruda was initially studied in only PD-L1 positives and where it was a beneficial treatment. And so it was approved just for that as a second-line treatment. So they all have very similar efficacy. I wrote 20% response rate or so, 15-20% in the second line, and that's the rate where the cancer shrinks significantly by about half. A lot of patients, more than 20%, will benefit, and that can be a little bit of shrinkage or stable disease when the cancer would otherwise be growing. And another thing that's worth knowing about immune therapy is that the scans are a little less helpful, or can be less helpful than they are when watching what they do on targeted therapy or chemo, where they shrink or they grow and that's it. With immune therapy, there's a concept called pseudo-progression, which is when the scan looks a little worse, but the patient's doing better. And it's not common. And it's a mistake to presume that every time you see the scan look worse, it's because you're being faked out. But it is important to see and incorporate how the patient's actually doing, because just today I saw a patient who had their first scan looked maybe a little worse, but his pain was less and he was gaining weight back after losing a lot of weight. It just didn't fit. And with further follow-up, I saw he just had a scan again. His second scan was a few weeks ago. It was way better. And so you don't want to throw out the baby with the bathwater. And so if the scan and the person and their story don't fit, give the patient the benefit of the doubt and keep going. What you don't want to do is have the scan look worse, the patient more in pain and losing more weight and saying, it must be pseudo-progression, let's keep going. You don't want to just chase good time after bad. I mean, you've got perhaps other options, but you don't want to just beat on a bad treatment. So just in summary, several agents are already approved and previously treated. They have appeared more similar than different. There are some differences, but most of us feel that they are close to interchangeable. Certainly, as second-line treatments, they have staggeringly similar results. They're moving increasingly into the first-line setting, and we're still learning about which patients are best served by getting immune therapy as a single drug first, which should be getting it with chemo, maybe some patients getting it in combination with 2 immune therapy drugs, but with greater toxicity. This is absolutely work in progress, literally changing day to day, week to week. And so that's great because we're only improving. We're subbing out something that looks pretty good for something looking even better. And then this is moving from advanced disease to earlier stage. Imfinzi, now approved and only a couple of months ago was approved as a new treatment that is becoming a standard for stage 3 lung cancer, may translate to more people being cured of this. And we are looking at different ways to use these drugs in earlier stage patients before or after surgery. And then Opdivo, with or without Yervoy, is being actively studied and increasingly used in small cell and mesothelioma. Next slide. And that's it. So stay tuned because this is all happening in real time.
That was awesome.